I don't like to do big lengthenings distally. So if I have a valgus distal femur, I don't want to do 8 centimeters of lengthening distally. It affects the quadriceps a lot. So sometimes it's better to divide it into 2 operations or do partial proximal plus a distal correction. And of course now we have internal lengthening devices, so I avoid external fixation as much as possible. I'm going to talk about the so-called oblique plane deformity. This is very common in orthopedic problems. We have, for example, on this example, on the AP view, you have a varus deformity of 17 degrees, but on the lateral view, you have a 15-degree apex anterior or procurvatum deformity. So what does this mean? How can you have a deformity in two planes? In reality, when you break a bone, there's no law that says it has to break purely in the frontal plane or purely in the sagittal plane. It can go in an oblique, non-anatomic plane. These conventions that we have using the anatomic position with patella forward, this is AP and this is lateral. This is just something that we as human beings like to think about. But the bone doesn't know about that. The bone can break in any direction it wants. And so when you have on the same bone a different X-ray deformity in 2 planes, it really means that you're dealing with one deformity, but it's in a non-anatomic plane. There's a few different ways to calculate that. One is the so-called graphic method, where you take a piece of graph paper and you say, okay, let's make the assumption, and it's not true, but it's an assumption that 1 degree is 1 millimeter. So for example, on the AP view, we have an apex lateral 17 degrees, so we can measure 17 millimeters and say that's 17 degrees. It's not really. And then on the, that's the direction of that deformity. And on the sagittal view, we can take our 15-degree deformity and draw 15 millimeters up this way. And then the resultant deformity, the true deformity, is in between. So if we complete the box, and I have to warn you, this is an approximation. And so those of you who like to be accurate, I'll show you a better method. But this is a good approximation, and this is something I literally do sometimes in the operating room, where I draw this, on the sheets using the touche, and I can draw this in 2 seconds, have my analysis done. So what this would tell you is that the hypotenuse of this deformity, if you measure that, that's the true magnitude of the deformity. So even though it was 17 degrees and 15 degrees, the true deformity is 23 degrees. And not only that, but it's in a certain plane, like 41 degrees off the frontal plane or 49 degrees off the sagittal plane. Now, why is this important? Well, it's actually not that important anymore, but it used to be important when we had the Ilizarov frame, because we had to build a frame with a hinge that would mimic that deformity. And if we didn't mimic that deformity precisely, we would get an incomplete or a wrong correction. So, I mean, literally, and I still do this once in a while, but now with modern methods of hexapod frames and computer-controlled correction, these things are, I wouldn't say they're of academic interest, but they're less critical because a lot of this is handled now by the computer without you having to think about it. I mean, nowadays you tell the computer you have 15 degrees of varus and 17 degrees of procurvatum. The computer does all this calculation for you. And so you don't, it kind of takes it out of our head. But it's nice to know where it comes from. And if you know, you can superimpose your ring on this little square diagram. It'll tell you where to put your hinges, where to put your distraction rod, and you apply the ring anatomically to the leg, and you can be pretty sure that you will be able to achieve a good correction of the deformity. So this we call the graphic method because we're making a graph. There's also the trigonometric method, because many of you like trigonometry. I mean, my eyes glaze over when I see arctans and things, square roots. But this is the true trigonometric analysis. So you can write down that formula if you like. But spoiler alert, you don't have to write down the formula, because Well, first of all, I'll just mention that the trigonometric method is the most accurate. And even though you got a certain value in the graphic method, the trigonometric method is the more accurate method. Now, who's got the multiplier app on their phone? Anybody? Okay. So hidden in the multiplier app, we've got the oblique plane deformity calculations. So I can put in, for example, that in this case we've got 20 degrees of AP deformity, 25 degrees of deformity on the lateral. In the AP it's varus, in the lateral it's procurvatum. Hit the calculate button and it tells me that I actually have a 30.6 degree deformity in a 52 degree plane. So the app now will do the calculation for you if you want to have it done. And that's more accurate by a few degrees anyway. But for most things that are within the range of orthopedic deformity, the graphic method works pretty well. Charlie Taylor came along about 25 years ago and he changed the whole game. He came up with the hexapod frame where you no longer have to do these calculations. You do have to put in the numbers. You have to tell it how much varus and how much procurvatum, but the computer will then do all the calculations and all the programs for you. Now, why do I still do this? Well, on a really small leg, like this is a child with a congenital posteromedial bow, where there's maybe not room for the hexapod frames, I'll still use the Ilizarov frames. And so it's useful, for example, here to know that we've got, in this congenital posteromedial bow, we've got apex medial deformity, apex posterior deformity, and literally this is how we draw these things, in the OR during the operation, and we can set up our frames. We know exactly which holes to put the hinges in, and we can pre-construct a frame, and literally done in the operating room and come up with something like this. So it seems like it's complicated, but it's really pretty simple. That's actually a double level frame. It's also useful for fibular hemimelia. We're dealing with these little tiny, 12 centimeter tibia. So this typically they have apex lateral deformity, medial deformity, and apex anterior deformity. But if you take this crooked little bone and you rotate it under the C-arm, you can make it look straight, just like the banana that Marie showed you. The banana looks deformed, but if you look at it a certain direction, the banana now is completely straight. So what you can do is just say, all right, I'm going to rotate the leg so the banana is straight, and I'm going to put my frame on in that plane so that it won't be an anatomic AP or lateral, it'll be something in between. But this is that technique. So you rotate the leg so it's straight. The knee is no longer pointing forward. It's a little bit off. But you can build your frame to set these hinges at the maximum deformity, which you can calculate, and then apply it so that the proximal rods are parallel to the tibia proximally, the distal parallel distally, the hinges are at the apex of the deformity, and this is at an off-plane axis. But this is something in a little small baby fibula, a baby tibia for fibular hemimelia. I do this technique all the time. It's just much easier than trying to calculate the specific angles. You just rotate the leg till it's straight, apply your maximum frame parallel to that, and then your hinges will be automatically set to correct both deformities. And call that the super ankle technique at the end of correction. So, when you're dealing with something really small, these concepts are not as important as they used to be, but they still have some relevance to my practice. So this is the oblique plane deformity when you have AP and lateral deformities in the same bone. It doesn't mean you have two separate deformities. It typically means you have a single deformity that's in a non-anatomic plane. It's not in the AP plane. It's not in the lateral plane. It's somewhere in between. Thank you.